We'd like to welcome you to Understanding GIST and Desmoid Tumors. My name is Sarah Rothschild. I'm the Executive Director of the LifeRaft Group. During this seminar, all participants should be muted during the presentations and feel free to, actually, I don't think there's an unmute feature, so we're good there. Please remember the information provided in this web seminar is not intended as a substitute for your physician's guidance and care. We would like to thank SpringWorks Therapeutics for their educational grant for today's webinar. Desmoid tumors are non-cancerous masses that form in connective tissue, and although extremely rare, it has been found that GIST patients could potentially develop desmoid tumors. Dr. Trent and Dr. Bialick of Sylvester Comprehensive Cancer Center will discuss this topic in detail for our community. I'd like to introduce you to our presenters. Dr. Jonathan Trent is currently the Associate Director for Clinical Research, the Director of the Bone and Soft Tissue Sarcoma Group at the Sylvester Comprehensive Cancer Center. Dr. Trent's interests are in the clinical and translational research of sarcomas, direct care of sarcoma patients, and education about sarcoma. And Dr. Stephen Bialick is a recent graduate of the Hematology Oncology Fellowship Program at the University of Miami, Jackson Memorial Hospital. He is a medical oncologist specializing in the care of patients with sarcoma and gastrointestinal malignancies at the Sylvester Comprehensive Cancer Center in South Florida. Dr. Bialick has a particular clinical research interest in connective tissue cancers and the role of circulating tumor DNA in solid tumor oncology. So I'd like to now transition it to our presenters and thank them for joining us today.
Thank you very much. Thank you for the introduction, and thank you all for joining us. We're excited to have you. Like Sarah said, my name's Steve Bialick, a recent graduate, but just joined the group at Sylvester as a sarcoma medical oncologist. And I'm excited to be here with you today, and I'll talk a little bit about desmoid tumors and then pass it off to Dr. Trent, who will talk about both desmoids and GIST. So if you can see my screen, maybe Dr. Trent, just let me know if you could see it. I think this should be, okay, great. So we'll talk briefly about desmoid tumors, who is affected and how they're treated as we go through the next couple of slides or so. And at the end, I think we'll have some time for you guys to ask some questions to us. So just a little bit of an outline of what we'll talk about. We'll go through an overview of desmoids and then move more into how we treat these tumors, which, as Sarah said in the beginning, these are non-cancerous or not malignant tumors, which we'll get into as we talk about some of the background behind these tumors. So desmoid tumors are also called aggressive fibromatosis. And as you guys know, there's lots of words and lots of language with long syllables and many hard to pronounce things that us doctors usually keeps us in business so we can pronounce it and other people cannot. But aggressive fibromatosis is just another name for desmoids. And these are benign tumors, which is a deceptive term because they are what we call locally aggressive. They don't have the potential to become metastatic, but they do have a high impact on the quality of life for some patients, depending on what the symptoms are related to this tumor. And while I don't want to get into too much of the science, these are tumors that come from a cell called fibroblasts. And those cells can turn into these growths or tumors, whereas those cells are initially meant or supposed to be involved in things like forming scar tissue or wound healing, but they have some sort of transformation or mutation that causes them to become desmoid tumors and grow into these masses. Where are they in our body? They really can happen anywhere. And sarcomas in general, which are connective tissue disorders, can happen anywhere in our body because we have connective tissue all over the place. So they're commonly, these desmoids, found in the extremities and the arms and the legs, but there's a good chunk of them, up to 40%, that show up in the abdominal area, whether that's the abdominal wall or inside the abdominal cavity. That's about 30 to 40% of these tumors. The clinical course of desmoids is rather unpredictable, and that's kind of what we're trying to get at when we study these tumors and how best to treat them, because we know that about a fifth of these tumors, 20%, can spontaneously regress on their own, whereas 40 to 50% of them may stay stable in size over the course of their duration. but about 30 to 40% of them will grow or progress. So on the bottom here, I have two graphs from a study that was done in 2018 where we were looking at a drug called sorafenib, which we'll talk about in a little bit. But looking at the left side, in this study, there were patients that got a placebo drug, and on the right is patients that got the actual treatment. And you can see in the patients that didn't get the treatment, some of them, based on this, what we call waterfall plot, some of them actually had some of their tumors staying stable in size or getting smaller by themselves. So that's kind of why when we talk about the treatment, the different options we have, whether we treat or whether we kind of focus on watching and waiting. Now, a majority of these tumors are not necessarily life-threatening, but of course they can result in significant burden on somebody's life, both psychologically and from a financial standpoint, because with certain symptoms, it can prevent people from doing things that they really enjoy doing or from the jobs that they were doing before they were diagnosed. Again, depending on the site of the tumor and how large it is and what areas around that tumor are involved in the growth. Again, it's rarely life-threatening, but there are times or some cases where they can become life-threatening because of where the tumor is located and whether or not that's compressing or pressing on different organs that are vital for life. And so when those arise, we have to talk about more aggressive treatments or more rapid ways to shrink the tumor or change its size or shape. Now, when we talk about why these desmoid tumors exist, we're not so sure. Most of them, or the majority of these cases, happen sporadically or at random. There's a small select few that can be related to a genetic mutation or a genetic disease called FAP, which we can talk about, but the majority, like I said, occurs sporadically, and we're not necessarily sure why. So looking at what we call the epidemiology, who gets the desmoid tumors? Well, they're rare, and they have what we call an incidence of about 2 to 4 per million people. So in the United States, about 1,000 to 1,500 new cases of desmoids each year. But they're again rare, and they comprise of less than 3% of all soft tissue tumors and less than 1% of all cancers in general, or neoplasms or growths. The peak age is about 30 to 40 years, and there's predominantly more women that get desmoids than men, in some would say 2-to-1 fashion. And like I said, there's 5 to 10% of these that come from a genetic predisposition syndrome or a hereditary syndrome called FAP. But again, the predominant desmoid tumor are random and sporadic in nature. There is an increased frequency of desmoid tumors diagnosed in patients that are pregnant or after pregnancy. And there's some thought that maybe these tumors are driven by the high estrogen or hormone state. And I would say about 1 in 4 or 25 to 30% of the patients that get diagnosed with desmoid at some point in their past have had some history of surgery, whether that's the C-section from having a baby or some surgery related to their genetic condition called FAP. A lot of patients have some surgery in their background. The pathology is not something I want to spend too much time on, but these are 2 slides. This is what the tumors look like under a microscope, actually. And there's a certain chemical or molecule called beta-catenin that's a little bit more involved than we need to discuss today. But this is what the tumors look like on the microscope. Now, how do they present? How do patients usually come to our office, and what are they saying is happening? Usually these are painless, sometimes minimally painful, sometimes more so, sometimes more painful, but usually they're painless growths that are typically slow growing. And depending on where these tumors are, they can cause symptoms related to that specific area. If they're in the abdomen or if they're near the gut, they can sometimes cause nausea. They can make you feel full faster, called early satiety. They can cause abdominal pain. If they're in the extremities, some people may present with a new limp or walking differently than they were walking before, pain in the extremities. But again, it's the symptoms are usually based on where the tumor is located. Now, how do we see these tumors? We can look on imaging, and there's many different modalities of radiography that we can use. One called an ultrasound in picture A, where we have this is where there's actually a mass that you can feel. uh, and look at with an ultrasound. In picture B, this is a CAT scan, which is basically a cross-section of the body, and we can look at tumors that are inside the abdomen or look for any complications, like we mentioned before. Are they involved in any of your vital organs or compressing any blood vessels or nerves? And then we have MRIs. Again, all of these images are black and white, mostly looking at size and shape of these tumors. But the MRIs are more reserved for patients with tumors in the abdominal wall or extra abdominal tumors in the extremities. We diagnose these by something called a biopsy, and the biopsy is crucial. And it's very important that these biopsies are done and these cells are looked at by special sarcoma-trained pathologists. And depending on the mutation analysis of these biopsies, we can confirm the diagnosis and decide whether this is more that random or sporadic nature or more from a syndromic or genetic condition. Now, it's important to know that there's really not one standard of care treatment protocol for desmoids. There's lots of different things we'll go through in terms of how to treat it, but there's really no textbook answer. Every case is different, and it all depends on what the symptoms are and what's going on in someone's life related to what treatments might be important. Now, I think I mentioned before about the nature of having a sarcoma specialized pathologist review the pathology. And why that's important is because sarcoma specialty centers, which have big, huge teams with doctors like pathologists and radiologists and medical oncologists like Dr. Trent and I, sarcoma-specific surgeons, these are important centers to get evaluated at because of the high volume of sarcoma patients and desmoid patients that we're seeing. And so it speaks to the nature of the multidisciplinary care team that we have. Now, how do we treat desmoid tumors? The treatment is like I said, no one size fits all. But when we think about surgery, historically, surgical resection was what we used to do to treat tumors, simply just remove the mass. The goal is to preserve the function of somebody's limb or the function of any critical structures. But we now know that there's a high rate of what we call local recurrence. Take the tumor out, but in that same area, it has about a 25 to 60% chance that it's going to come back. And the surgery itself can carry some risk of morbidity. The tumor sometimes has to come out with a big chunk of tissue around it to allow for a complete resection. Now, there's other types of sarcomas where it's very, very important that we remove the tumor in its entirety to prevent or limit the chance of recurrence. But there's some cases of desmoids where we're just trying to take some tissue out, not necessarily all of it, to get some symptom relief or move it away from critical structures. So again, not every surgery is the same and not all treatments are the same, but the surgical decisions are very complex, and that's why this multidisciplinary approach is really something we're looking to have. In terms of radiation, we don't typically recommend radiation for desmoid tumors. It's sometimes considered if there is what we call positive margins. The tumor is removed, but there are some cells left behind. But there is a risk of developing what we call radiation-induced sarcoma, which these are actual malignancies that can develop on a background of radiation. So we try to limit the use of radiation if we can. But if it's deemed beneficial by the multidisciplinary team, then we can think about it and use the dose of radiation or the duration of radiation in various different ways. There is the famous active surveillance or the watch and wait method, where we can simply look at somebody's clinical picture, physically how the size of the tumor is affecting their life, and look at these radiographs, whether that's the MRI that we showed, or the CAT scan, or the ultrasounds. And we can do this, frequently or infrequently to determine if there's any growth or any change, again, in the size and shape of your tumor. Because we said before, many of these desmoid tumors, about 20% of them can regress on their own, or a good portion of them remain stable over time without causing any symptoms or dangerous sequelae. If the tumor progresses or if the symptoms increase, this is a time where we can move from the watch and wait treatment into more active treatment. And there is earlier treatment if the tumor is around any of these critical structures. So how do we treat them? What are the types of systemic therapy we have? Well, the patients who get systemic therapy are those that are deemed to be unresectable and symptomatic. Unresectable meaning taking the tumor out would cause a lot of morbidity or a lot of side effects from the surgery itself, and the tumor is causing pain or a change in kidney function or liver function or something of the sort. There are also patients that are asymptomatic, but the tumor is progressing quicker, or on the images, we're seeing progression rapidly. If someone had the tumor removed and it came back, had the tumor removed and it came back, we call that local therapy with loco-regional recurrence. And if that's the case, then systemic therapy may be an option for you. And again, symptomatic and potentially resectable tumors, that surgery would cause some unacceptable morbidity. We often favor systemic therapy for that too. So there's many different kinds of therapy, whether we use pills or oral therapy, a group of medications called tyrosine kinase inhibitors. The most common is a drug called sorafenib. Its brand name is Nexavar, but we also have a drug called Votrient or Sutent. And then there's the age-old group of medications called NSAIDs, Advil, ibuprofen, Tylenol, which sometimes can help with pain. And there was some school of thought about the hormone-driven tumors and using some hormone therapy or anti-hormone therapy. But there's a newer drug that has been studied, and a new, fresh this year paper that came out in the New England Journal of Medicine with a drug called nirogacestat, which was the most recent phase 3 study, a trial with lots of different institutions studying this drug. And the FDA is gonna meet on this drug again in November to see if it'll gain approval for desmoid tumors, which would actually be the first drug FDA approved for this disease. So our fingers are crossed, and we're kind of waiting for that news to come out, and we're a month or so away, but we'll see what happens with that drug. I got really excited about using emojis in a PowerPoint because my MacBook now lets me click symbols and add what my phone would actually put in. So I thought this was a cool slide for you guys to see the drugs and the common side effects. And it kind of hammers home the most important ones for each drug. So the top 3 are the tyrosine kinase inhibitors, sorafenib, pazopanib, and sunitinib. And you'll see a lot of these drugs, the side effects include fatigue, some diarrhea, some rash, some changes in taste, and related to those taste changes are changes in your appetite and weight loss. But a lot of these drugs the side effects can be managed in our clinic with close observation and treatment with your doctor. But the drugs all have some side effects, but this is why we always weigh the risks and the benefits of treating someone with medication for the tumor. There's also chemotherapy, which we typically reserve for patients that have impending threat to these vital organs, a big tumor that's going to impede on a blood vessel, something of this sort, a cause of bowel obstruction. We use medication like chemotherapy that's usually given intravenously. And there's many different formulations or combinations we can use, but these are the ones that we typically we pick. As far as desmoids, that's the bulk of what I wanted to talk about to you guys about some general background of desmoids. And when we get to the Q&A session, if you guys have any questions about it, Dr. Trent and I are happy to answer. This is our big team down in Miami at Sylvester, but you can see it, it takes a lot of people to treat sarcomas, including desmoids. And we have a big, huge team at Sylvester that we're very proud of. And I thank you guys again for the invitation and for your attention. And I'll pass it over to Dr. Trent to talk about more about desmoids, but also some about GIST too.
Thank you, Steve. That was a really great overview of desmoid tumor, its diagnosis and management. So I'll be taking that introduction and discussing a little bit about GIST and other cancers. Can everybody see this okay? All right. So, so I started my career after my fellowship with an interest in sarcoma, particularly GI stromal tumor. And I've also had an interest in desmoid tumor. And I'll show you a little bit of how that evolved over time. So as Steve mentioned, there are 175 different types of sarcoma, 175. And each one is a different type of cancer, just like breast cancer is different from colon cancer. Well, desmoid tumor is different from GI stromal tumor. Our pathologists name these tumors many times based on their similarity to normal tissue or some other type of descriptive terms. So gastrointestinal stromal tumor is a type of sarcoma that arises in the GI tract. Desmoid tumor is a type of sarcoma that arises in the soft tissues, as Dr. Bialick mentioned. Sarcomas are also molecularly driven. So GIST is often caused by a mutation in KIT or PDGFR. Desmoid tumors, as we heard, are often caused by a mutation in beta-catenin or a molecule called FAP. We heard some of the discussion about different treatments, including surgery, radiation, and systemic therapies for desmoid tumor. The same is true for GIST. We use surgery, occasionally radiation therapy, not that often, but it can be useful in select situations. And then when patients may not be able to have surgery or after they've had surgery, we may use a targeted therapy that I'll discuss in a little bit. So GIST is the most common sarcoma of the GI tract. It's a rare GI cancer, but it may be the most common sarcoma if you count the numbers. There's a high frequency, unfortunately, of GIST spreading to other sites about half of the time with a primary tumor. There's risk of it coming back in the abdomen, or there's risk of it coming back in the liver or other locations about half of the time, even with these new treatments. The new treatments have, like imatinib, have decreased the risk because they're very effective. Gene mutations really drive the GIST and determine the treatment. All of the bad things that a GIST can do are determined by what type of mutation there is. And the medicines we use to treat patients are determined by the type of mutation. The most common type of medication we use to treat GIST patients are called tyrosine kinase inhibitors, or TKIs. And now we have 5 of these medicines FDA approved for GIST patients. And we're doing clinical trials here at Sylvester with new ones as well. So there's a lot of hope in the future for GIST patients. We think our laboratory research is identifying ways to make these medicines work better to get us closer to a cure. It's really going to take a lot more research to get to that point, and we're passionate about it here at Sylvester. So GIST most commonly is caused by a mutation in a gene called KIT. This is a cartoon reflecting that mutation. Those mutations most commonly in an area called exon 11, not the gas station. An exon is an area or a region within this protein. And 11 just inside the tumor cell is the most common site. Exon 9 is another common site just outside. It's important because these mutations activate the kinase, just like turning on a light switch. You turn on the light switch, it sends electricity to the light turns on. When there's a mutation in KIT, much like the electricity, it sends a signal into the nucleus of the tumor cell, and that signal drives expression of new genes into new proteins that are not normally there. Those proteins then do the bad things that tumor cells do, such as proliferating or splitting from 1 into 2, 2 into 4, 4 into 8, 8 into 16, 32, 64. Next thing you know, you have a tumor. Cells in our body normally die. They have a finite lifespan. Some of these mutations prevent that process, invading into the blood vessels, getting to the liver or other sites. And this seems to all be driven by the activation of the KIT receptor, turning on the light switch. Now, imatinib and these other TKIs that we've discussed previously, they bind to the KIT receptor and lock it into the inactive structure, much like turning off the light switch. And when you turn off the light switch, that shuts down all of these bad characteristics that the tumor cell has developed because of the mutation. And this is effective in GIST patients 80 to 90% of the time. So it's highly effective, especially if there's the KIT mutation. Now, in addition to exon 11 and 9, we've noticed the rise and emergence of resistant mutations in a different area called 13 and 17. And then there's some patients that might have a GIST that has a different mutation, such as PDGFR, SDH, RAF, NF1, and these are all treated very differently. Unfortunately, in the United States, mutation testing is not performed as often as it should be. To me, this is really mind-boggling because I wouldn't know how to treat a GIST patient or what medication to treat a GIST patient with. Plus, we can learn about certain risk factors based on mutations. Yet, only in 2015, just under 30% of GIST patients were getting mutation testing. 70% of patients these are metastatic patients, were being treated presumably with some medicine without knowing whether there's a KIT mutation or one of these other mutations that might be tested with a different medicine. And so that led us to really increase our educational activities and increase our research into mutation testing in order to raise awareness and ensure GIST patients are getting tested so that we know and so that they're getting the right treatment. And Dr. Bialick has been pioneering the use of circulating tumor DNA. Instead of sticking a needle into a patient's abdomen or into their liver and doing an invasive biopsy such as that, we can now use blood from a routine blood test, such as when a patient goes to see their doctor, gets a blood test, we can send some of that blood for circulating tumor DNA testing. And that can tell us what type of mutation is in the GIST, whether there's a resistance mutation, etc. And I'd be happy, and Dr. Bialick will be more than happy to discuss this offline. In fact, it's so important that we've opened a clinical trial here at Sylvester to prospectively test patients' tumors for circulating tumor DNA and then treat them with the medicine that is predicted to give them the best result. And so now the state of the art, in our opinion, for treating GIST patients with systemic therapy is driven purely by the type of mutation in the patient's tumor. And so with that background, we can discuss a little bit about other cancers. So I've been seeing GIST patients for about 20 years. I've seen over 2,000 different GIST patients in that time. And a few years ago, we were seeing, with that high volume of GIST patients, we were noticing patients that had other cancers. And it seemed to be more common than we expected, particularly lung cancer. And I'll just give you an example. For instance, there was a patient that I saw here at Sylvester who was referred to me for metastatic GIST. The patient had a GIST, had it resected, had taken adjuvant imatinib a few years ago and was doing great. But they had this lung nodule. Well, we know from our experience that GIST spreading to the lung is very, very rare. We don't see that very commonly at all. So the first thing we did was do a biopsy. And so when we did the biopsy, we found out, in fact, the patient had a primary lung cancer. So the patient had surgery and was cured from the lung cancer. If we hadn't done the biopsy, we would have put the patient back on imatinib or treated them with other kinase inhibitor, and it wouldn't have been effective and it would have grown. And so it's important to understand the metastatic pattern of GIST and have a low threshold for doing a biopsy. So we looked back on a series of GIST patients who we saw confirmed with GIST by our sarcoma pathologist and evaluated them for additional cancers. Now, we excluded non-melanoma skin cancers. There's literally 1 million non-melanoma skin cancers a year in the United States, and there's about 1 million malignant cancers that are not basal cell or squamous cell carcinomas. So we excluded the non-melanoma skin cancers. We collected information on age, race, ethnicity, gender, and we had collected tumor characteristics, the timing of the diagnosis, and we also collected information on imatinib and other therapies. We wanted to make sure that imatinib wasn't causing other cancers. And so this is a graphic demonstration of the other cancers, the other malignancies that we observed in GIST patients. So of the 786, there were 153 patients with other cancers. A third of those cancers were genitourinary. So we're talking prostate, we're talking kidney cancer, we're talking bladder cancer. So that was the most common second cancer. The other common cancer was GI carcinomas. Now, these are all carcinomas. But then we also saw, so that's gastrointestinal. So that's a stomach carcinoma, a colon cancer, a liver cancer. And so it's important because the GIST is in the GI tract. If you see a mass in the GI tract, you have to have a low threshold for suspecting other cancers as well. And then breast cancer, hematologic malignancies, even other sarcomas, which we'll talk about in a little bit, such as desmoid tumor. Well, what we found was that of the 783 patients, 153 or 20% were diagnosed with a second malignancy. About 4% had 2 or more other cancers in addition to their GIST. So 3 cancers in about 4% of GIST patients. These were slightly more common in men, and the median age was around 66, just at 66. A little bit older than the median age of GIST patients, which is around 54. Prior to GIST, the most common second malignancies were prostate and breast cancer. After the diagnosis of GIST, patients were found who developed a second malignancy were found to have lung or kidney cancer most often. So very different patterns before GIST and after GIST. Importantly, patients with GIST who develop a second malignancy have exactly the same survival. There's no difference in outcome of their GIST or their other cancer if they're treated as an individual cancer. So, for instance, the patient I was describing earlier that had a newly diagnosed lung cancer, we didn't pay attention to the gist. We treated the patient with intent to cure them from the lung cancer. And when you do that, you get the same survival as a patient who doesn't have any other cancer from their gist. We only saw a decrease in long-term outcomes if there were 2 or more additional cancers. And it was a small amount. It was only about a 10% decrease in the 10-year survival rate. So the bottom line is that a GIST patient diagnosed with a second malignancy should be treated just like they didn't have the GIST. They should be treated with the intent to cure, and the outcomes will be the same, whether they have GIST or not. So I was mentioned that there were some GIST patients that developed sarcomas. There was about 5 in our study. Well, it turned out that 2 of them had desmoid tumor, and I saw them back to back in clinic. And I was working with a graduate student named Marie Dumont, and Marie asked me if that was common. And I said, no, I don't think I've ever seen that before. And then he asked me, is there a relationship between GIST and desmoid tumor? Or is this just due to chance? And so he turned that into a research question. And so that led us to try to use a statistical method called a standardized incidence ratio to determine whether the occurrence of GIST and desmoid tumor were due to chance, or whether there was a relationship that went beyond being due to chance. So GIST and desmoid, they're rare mesenchymal tumors or sarcomas. I mentioned some anecdotal reports of individuals with both. I called around to some other sarcoma centers around the country and emailed some colleagues in other countries and asked them if they had seen GIST and desmoid tumor. And it turned out everybody I talked to had seen a few patients, 1 or 2 patients with GIST and desmoid tumor. So we evaluated the existence of these 2 tumors in a multi-center cohort from 10 institutions around the world, as far as Australia. We collected data on gender, age at diagnosis, types of mutations, and follow-up time after diagnosis with each tumor. And this is an example of a patient. This is a CAT scan. The radiologist put an R here telling us that's the patient's right. This is the patient's left. They're laying on their back and they're looking up. This is the front. And so this is a cross section through the patient. Air is dark, it's black. This is air in the GI tract here by the arrow. Fatty tissue is a light gray, and then vascular tissue with blood vessels carries the IV contrast and is a brighter color, a brighter gray. And then bone is white because it's calcified and the x-rays can't go through it. So at the top left, you can see this GIST this patient has staying stable over time. We increased the dose of imatinib up to 800 and it shrank. This was a biopsy confirmed GIST in the patient's stomach. You can see it arising from the wall of the stomach, biopsy proven. But then the patient developed this lump on their chest. And, it's a little subtle. You can see the arrow and by the DT, but the patient noticed the lump. Asked me to examine it. I examined, and there was some asymmetry. You can compare to the other side, and it's asymmetric. And then we noticed that after we increased the dose to 800, the tumor shrank some. You can see it flattening out here. And so this patient went to surgery and had both resected, and the abdominal wall lesion is an unusual location for GIST, right? The abdominal wall lesion ended up being a desmoid tumor. And so we ended up with 4 patients with GIST and desmoid tumor in my practice. And we identified other patients. And this is just to show long-term outcome is great for patients with GIST and desmoid tumor. We identified 28 patients with both tumors. We found that desmoid tumor was diagnosed after GIST 75% of the time, and diagnosed at the same time in 21%. It's very rare to get GIST after desmoid tumor, but it happens. There was one, it happened in 4% in our study. We found KIT mutations in the GISTs, and we found beta-catenin mutations in the desmoid tumor, and we didn't find the converse. And so we took the incident, so we looked at the number 28 patients, and then we looked at the number in the population at those institutions. And using the known incidence of desmoid tumor in the world, we could calculate what is the incidence of desmoid tumor in the general population. And then we could calculate the incidence of desmoid tumor in patients with GIST. And we found out that if somebody has a GIST, they're 82 times more likely to get a desmoid tumor than somebody in the general population walking down the street. And so we continue to see patients with GIST and desmoid tumor. It's not unusual. I think that the 82-fold increase may be an underestimate, in fact, because not every patient with desmoid tumor and GIST is getting their desmoid tumor biopsied. It has to be from an experienced sarcoma center who knows that there's an association and has a low threshold for doing this type of biopsy in order to understand whether this is GIST that's enlarging or it's a desmoid tumor that may be treated differently. And as we heard from Dr. Bialick, there's new treatments on the horizon, such as nirogacestat, that could be an option for a patient who has GIST and desmoid tumor. And so I worry oftentimes how many GIST patients there are out there that actually have a desmoid tumor and it hasn't been biopsied, and they keep getting treated with TKIs that aren't working. And I suspect it's happening. I don't know how often, but it's another reason that GIST and desmoid tumor patients should be seen at Experienced Sarcoma Center. And so the graduate student, Anne-Marie Dumont, published this series in the Annals of Oncology. And here at Sylvester, we call it Dumont syndrome for GIST and desmoid. Everybody knows what that is here. I don't know if the rest of the world knows what that is, but that's our nomenclature here at Sylvester. And, to really give credit to the person who did this research and made this association known to the world. So we do have some GIST trials. We don't have any desmoid tumor trials currently, but IDRX-42 is the next generation KIT inhibitor. As I mentioned, we have this phase 2 clinical trial where we use the results of ctDNA to guide therapy for GIST patients. Any line of therapy, but they have to have a mutation detected. And then we also have the two phase 3 studies for GIST patients, second line and second line. As Dr. Bialick mentioned, we have an awesome GIST and sarcoma and desmoid tumor team here at Sylvester. I'd like to thank everybody who is doing the research and taking care of the patients that really need it. Thank you all, and I'd be happy to answer any questions. You can also reach me by email or on social media. Thank you. And thank you all for taking time out of your busy schedules to spend an hour with us discussing these rare cancers. And thank you, Sarah and the Life Raft group for hosting this important event that, many people wouldn't know about if it weren't for the Life Raft group.
Thank you. Thank you so much. That was great. Really lovely conversation and presentations that were shared today. We do have a question. Hopefully more can come up. You guys can submit them in the Q&A and chat. We got to start a movement of identifying this combination as the Dumont syndrome. I learned about that from Dr. Trent as well. So see if we can create a wave there. And also, I really enjoy the emojis that Dr. Bialick had found to connect to side effects. We got to create a movement there, maybe include that in some scientific congresses and make that the Bialick movement.
Yeah.
Anyways, so let's get started. The first question relates to circulating tumor DNA. I know both Dr. Trent and Bialick are involved with that. This patient wants to know if they can share regarding a blood test for circulating tumor DNA. They wanted to make sure, is a tumor sample required?
So if I understand your question correctly, you're asking if we still use tumor biopsies for GIST in general, or if there's a companion liquid biopsy, and if that's what your question is. We do use liquid biopsy, this circulating tumor DNA blood test, which can identify and help us identify these mutations that can help us, or hopefully help us, select the right treatment based on the mutation. But typically, when you're diagnosed with GIST, in the beginning of your diagnosis, we still favor getting a tissue biopsy to prove that that's the disease that you have. But more and more, we're seeing that if the disease, unfortunately, is progressing, or if the tumor is spread to other areas and you have metastatic disease, the likelihood of identifying one of these mutations from the liquid biopsy or the circulating tumor DNA is more and more helpful. And so to get a liquid biopsy or to get a ctDNA test, each time, your doctor tells you that the scans look like the disease is getting a bit more progressive, that's something that we do routinely in Miami and is very helpful for selecting or identifying these new mutations that could arise. Is that what your question was?
Yeah, just getting more information regarding that blood test. I think it was
Sure.
new, and regarding what can you learn more about circulating tumor DNA?
Sure.
Yeah, you can always talk with your physician who's taking care of you to get more information about it and whether it's indicated. And so there was another question about the removal of GIST surgically and the risk of getting a desmoid tumor. So there is a situation called a scar desmoid, where the desmoid tumor forms in the scar tissue from a prior surgery. We published a series, Filipos Costa, when he was with us, published a series of 12 patients with desmoid tumor who had the tumor arise in the scar from breast implant surgery. And there's other examples. And so it can arise in scar tissue from a prior surgery. That is something that has been described. And then there was a question about the relationship between other cancers in GIST patients after COVID vaccination. That's not something that we have observed. The data that I showed today is prior to COVID, a long time prior to COVID, and not related at all to COVID vaccine. I'm not aware of any relationship between any of the COVID vaccines and cancer.
There's a question. Oh, yeah, go on.
Oh yeah, I see the question from about the size of the tumor, if the GIST is 6.5 centimeters in size, and whether surgery or medication is the right decision. And like we said, this is often a multidisciplinary decision with the surgeons and the medical oncologists like Dr. Trent and I about the best approach. Sometimes, depending on the size and location of the tumor, we can use medication to shrink the tumor so that the surgery is either easier or more successful. but there's different factors that go into play when we look at not just the size, but the grade of the tumor and what the biopsy shows of that sample. So typically there's a lot of different decisions that come into play, but whether or not we're using medication and surgery or just surgery alone depends on a lot of other factors, in the decision making.
Yeah, agree. And then there's another question about GIST and desmoid tumor removed a year ago, and what would there be a reason for retesting for mutation, and how often should they have radiographic imaging performed? So in our practice, we would do the mutation testing at baseline, like at diagnosis, and then don't really repeat mutation testing unless there's resistance to imatinib for the GIST. Generally doesn't need to be repeated at all for the desmoid tumor. To have them both removed surgically is fine and appropriate in the right setting in the context of everything that Dr. Bialick discussed. As far as follow-up, we generally see patients every 3 months for 2 years, every 4 months for 2 years, 6 months for a year, and then once a year after 5 years. We do CBC chemistry blood tests, and then we also have a chest X-ray and a CAT scan of the abdomen and pelvis with and without IV contrast. We're using water as oral contrast currently and seeing great results.
Okay, well, this person, there seems to be an interest in terms of the comorbidities of different cancers popping up with GIST. This person was interested in kidney and liver cancers. Do you want to touch upon
Yeah, there is some risk of kidney and liver cancers in relation in a patient with GIST. Now, you have to also realize that patients with GIST are getting CAT scans.
Yeah.
People walking, average person without cancer walking down the street isn't necessarily getting, probably not getting CAT scans. And so when you do CAT scans, you find things. So there's also an element of the incidental finding of liver and kidney cancers in the GIST population by virtue of the fact that that patients are undergoing CAT scans. But but we do find it, and if you see something like that, you can't assume that it is a GIST metastasis. You have to do the biopsy.
And just to clarify, when you say that there are patients that are undergoing CAT scans frequently for GIST and surveillance, I want to just make the point, you're not saying that patients getting CAT scans are at increased risk of developing other cancers because of their CAT scans. We're finding that patients have cancers on these CAT scans unrelated to the amount of times they're getting scanned, because we have a lot of patients that are fearful of getting scans repeatedly for surveillance because of the radiation exposure that comes with these scans. But it's really limited radiation in terms of getting these scans for the most part.
Yeah, agree 100%. There's no evidence that CAT scans cause cancer, especially the high resolution, low radiation CAT scans we're doing these days.
They say you get exposed to more radiation flying than you would from the scan. Any other questions that people want to submit? Some more time to type. Okay, I don't think any other questions are coming in. I think you guys were quite thorough with the topic of GIST and desmoid. I want to thank you both for your time today and for shedding light on this important topic. And there's somebody who wanted to ask about the new medication that was discussed. I don't know if you want to. Oh.
Yeah, we're hopeful nirogacestat's great. It looks very promising in the clinical trials with a 40% response rate.
Excellent.
Yeah.
Okay, so
We,
we'll have
we are
to stay
excited in
tuned.
our world.
Yeah, we'll have to stay tuned for the news. You said in November, right?
That's what I hear most recently. I think, yeah, fingers crossed. It was August, now it's November. So the paper was published in the New England Journal, I think in March, with the data from the trial. I think we were part of that trial, but yes,
Yeah,
as
Dr. D'Amato was one of the authors on that
and
clinical trial
Dr.
publication.
Trent said the response rate was about 40% compared to the people in the group that didn't get the drug at 8% response rate. So we definitely see a big difference in the drug. So we're hopeful.
Okay, so here's to more hope for our patients who are listening today. And thank you to teams like the Sylvester team that's here today, because you guys set a really great example of how a medical multidisciplinary team should operate in supporting the patient community. So thank you both for your time, and stay tuned for the archive of this presentation later on. All
Take
right,
care.
have a lovely day. Bye,
Thank
everyone.
you. Have a good day, everybody.
Bye, guys.